The subscapularis bearing flipped Latarjet procedure, a new concept for treatment of recurrent anterior shoulder dislocations with glenoid bone loss. This is a case presentation of a 27-year-old male patient after a failed arthroscopic Bankart repair 3 years ago. This patient had multiple recurrent anterior dislocations afterwards, and in the CT scan you can see that there is significant bone loss anteriorly. This is the video showing the shoulder joint of this patient with significant bone loss anteriorly. There's an intact subscapularis tendon as well as long head of the biceps and the rotator cuff. There's a flat Hill-Sachs lesion. The inferior capsule is intact. There's no Hagel lesion. We prepare the undersurface of the coracoid after taking out the rotator interval, and we make a release of the lateral conjoint tendon. Then we take out the remaining sutures from the previous surgery, and an anterolateral portal is established. The camera is switched into this portal, and now the anterior part of the glenoid is prepared by using a burr, creating a nice and flat surface with cancellous bone. A posterior drill guide is introduced, and now by using 3 mm cannulated drills, we are drilling from posterior to anterior, usually at the 5 o'clock position and 3 o'clock position. The vessels and the nerves are not at risk by drilling from posterior. The drill guide is removed and the cannulated drills are loaded with metallic wires, and those are replaced by fiber links. The same is done for the superior drill hole, and then the sutures are retrieved posteriorly. Now we prepare the conjoint tendon and we identify the axillary nerve. The lateral part of the coracoid process is prepared and we create a deltopectoral portal. The camera is switched into this portal and we release the medial part of the pectoralis minor muscles. Care must be taken for the musculocutaneous nerve. The superior surface of the coracoid is debrided and we can measure the dimension of our coracoid. The superior drill guide is now introduced, coming from superiorly, and first 1.1 mm K-wires are used to check the correct positioning of our drill holes. Once the K-wires are placed correctly, we can over-drill them by using the 3 mm cannulated drill. Again, metallic wires are used for shuttling the fiber links, and afterwards the bone block cerclage can be shuttled through the bone. In this case we use a supportive plate underneath the coracoid to avoid a cut-through of our cerclage in between the drill holes. A stressorizer is now created with a burr at the base of the coracoid, and by using an osteotome we make the osteotomy of the coracoid. The coracoid process should be released completely. Oftentimes you find a bleeder inferiorly that should be treated. Now we start the shuttling of our cerclage. First, the cerclage from the base of the coracoid is shuttled through the inferior drill hole at the glenoid, and afterwards the cerclage at the tip of the coracoid is shuttled through the superior drill hole. Now we internally rotate the arm in order to relax the subscapularis. By using a switching stick and a probe, we can easily flip the coracoid process above the subscapularis tendon, and you can see that we increase the surface of the bone anteriorly with the glenoid bone block. The bone block is lying flush to the anterior part of the glenoid. The conjoint tendon is running above the subscapularis tendon while keeping the sling effect, and the subscapularis muscle is not split and not damaged. By rotating the arm you can see that the subscapularis tendon is running underneath the conjoint tendon. Postoperative X-rays are showing a correct placement of the bone graft at the anterior glenoid. Thank you very much.